is I'll just quickly share that web page so that if people watch back that they can see that. So if those joined, Emma was just letting us know about the Sabo Mind, which has lots of mental practice pre-recorded, pre-designed scripts. Oh, they look great. There's loads. So that might be a really good resource because we did explore mental imaging, but it takes quite a lot of time to develop those resources, and Sabo have done that bit.
I would say they're very thorough, they're very in-depth, and actually probably more in-depth than we would potentially have done them ourselves. So yeah, definitely worth having a little look.
All free to access as well, aren't they? Which is great.
Right, we're going to get started on today's session because, as I mentioned a little while ago, there is absolutely loads of great content to get through. So I'm going to switch and start slides. Hang on, there we go. So today's session is part 2 of our focus on spasticity management, and we're focusing on the pharmacological side of its management. So we're just going to do a really quick recap from what we covered last time, just to get everyone back thinking about spasticity and its management. I'm going to touch on oral antispasmodics. Isn't the primary focus of the session, but we're just going to give a really quick overview of oral antispasmodics, when they might be useful, different types of oral antispasmodics, and then we're going to move on to what the main session is about, and that's the focal management using botulinum toxin. So you've got myself, Karen and Emma presenting today. We're going to switch between us, and these are our goals. Hang on, sorry, not switch. So got 2 goals of the session. We'd love you to come away with having a knowledge of both the oral and focal management options for spasticity, and to have an understanding of the impact and role of botulinum toxin in the management of spasticity. So like I said, I'm going to give you a quick recap of what we talked about last time. If you weren't able to attend last time, or I really encourage you to watch back the recording of the last session. So we talked about how spasticity was a consequence of upper motor neuron lesions, and it has wide-ranging and profound impacts at a personal level, social and economic level. It's associated with a reduction in quality of life, increased dependency, higher carer burden, and higher healthcare needs and costs than stroke survivors without spasticity. We also know it affects up to 49% of stroke survivors, with 18% experiencing severe and disabling spasticity. So most definitely a consequence of stroke we should be assessing and managing. One of the challenges is it has variable onset time, which poses a challenge to us in clinical practice, but we do know that we have predictive risk factors, and those are those patients with significant and dense weakness, sensory impairment, large volume strokes, high NHISS, those patients experiencing pain and lack of agency. So we know which patients are more likely to develop spasticity. And with that knowledge, we should be undertaking patient screening to ensure we deliver targeted and personalised interventions, proactive management plans, and educating our patients on spasticity management. Okay. As I said, the recording from the last session is available on the Teams page, and I'll try and work out how to put it in the chat after this as well. So it's really easily accessible if those that couldn't attend or want to just recap themselves. Now, these are the recommendations that we presented to you, and they're not our recommendations, they are expert consensus recommendations. The reference is in the top corner, and that's that all teams undertake a post-stroke screening assessment to indicate risk of spasticity. So that's looking at those predictive risk factors and identifying which patients fall into that category. Assessing spasticity should be embedded into standard clinical routines using standardized methods of early identification. We talked about those assessments as well, and what those should, what a spasticity assessment should contain. Patients should be monitored according to their risk of spasticity, and we should be using a tool to assess and identify post-stroke spasticity. And one of the tools that we shared with you was this, out of the same recommendations, is that patients who are at risk should be have some sort of monitoring in place. And then finally, we went on to talking about therapeutic management. We've concentrated on this section here. We're just looking at what can we do from a therapy perspective to manage patients. So that's bringing in all your therapy modalities that could form part of a management plan. And today we're looking at this section, which is oral antispasmodics. You see they're recommended for generalized spasticities, but sometimes can have a place in the focal management. And then we're going to move on to the focal management with botulinum toxin, where we're going to spend most of our time today. This session was predominantly set up as a stroke learning forum, so we're focusing on those options that are more commonly used within stroke populations. You can see on the chart there that phenol nerve and muscle blockades are an option in the focal management, as are intrathecal baclofen and phenol for segmental spasticity. However, they're less commonly used in this population, and they're also not services that we're able to provide locally. Okay. For those that attended last session, you were asked to sort of pledge at the end what your change in practice would be or what you would do following that session. So I just wanted to recap some of those. People said they were going to have more discussions with family members and carers around education and management, which is great. And one of the things that sort of shared, and if you hadn't seen it already, was the different strokes, spasticity after stroke leaflet, and also the ACTION acronym, which is around the routine monitoring of spasticity after stroke. And I'll share those again at the end of the session, but they are all on the Teams page as well. Utilising the modified Ashworth scale in discussions and communication of spasticity, liaising and referring more into the MDT, to pay extra attention to the triggers that drive spasticity and the risk factors our patients present with to assure regular reassessment. So as you said all those things, we really wanted to pull out how important it was to monitor patients, review patients, and give them the education so that their carers and the patients themselves can be in better control of their own management. So we're going to move on to content this morning. I'm going to start off by looking just at the oral antispasmodics. Okay, so there are a number of different oral antispasmodics, and they work at different levels. The majority of oral antispasmodics, they are taken in an oral form, as the name suggests, so they're going to have systemic effects. So they're not going to target one individual muscles, which is why they're more commonly thought to be appropriate for global spasticity. However, as said in the introduction, there is a role for them in the management of focal spasticity. We just have to be really careful. So the one that's commonly used in stroke is baclofen. It's a GABA agonist, and it binds with your GABA B receptors at the spinal level, preventing signals to the motor nerve and inhibiting your stretch reflex. Tizanidine and diazepam also work in the spinal cord. And then you have dantrolene, which is your which works at a muscle level, and it decreases the calcium release in the skeletal muscle. And it's the only peripherally acting oral medication. Okay. As I said, they are all oral medications, and therefore they have systemic effects, and they also have side effects. And whether a patient is appropriate is a very patient-specific decision, depending on the severity, the risks, and also potentially your access to focal management. So this isn't an exhaustive list, but these are some of the common side effects need to be mindful of when someone is started on an oral antispasmodic. So sedation and drowsiness and fatigue, dizziness. Said it's a can cause muscle weakness, postural hypertension. And there's also an issue that it has to be titrated, as well as being titrated up when it's started, it also needs to be titrated down, otherwise patients can experience withdrawal symptoms. So when I'm prescribing in my practice, I will also sort of be considering the other medications they're on, their past medical history, their ability to absorb and excrete medications, and I'll be weighing that up with the risks and benefits of starting that medication. So, as I said, they can be helpful. They can provide us a window for treatment and management. If there's a significant risk of contracture or loss of function, hygiene, all those really negative effects of spasticity, or spasticity is considered to be driving pain, but we need to think about whether spasticity is helpful. Talk lots around the negative impacts of spasticity, but some patients do use spasticity in their function. An example of this might be using lower limb extension tone to stand and create a stance phase and gait, but maybe the patient also has problematic flexed upper limb. We may not want to start an oral medication which has general side effects if they're using their lower limb tone for function. These medications also need slow and careful titration and monitoring of the adverse effects, which can be tricky. And it's tricky to do in a bedded setting, but can be tricky to do in a community setting as well. Not on this chart, and I've just realised I skipped over it, is that gabapentin and pregabalin, they are anti-seizure medications and generally thought to be, or generally used when you've got neuropathic pain, but they also act on the calcium channels within the muscle and can have an antispasmodic effect as well. So they are also options to use. So as I said, the aim of this wasn't to give you, this is what should be used with patients, it's just to give you that overview around oral antispasmodic medications before we moved on to the focal management, which is what today's session is really about. So botulinum toxin, Botox is the trade name. So botulinum toxin is a neurotoxin produced by the bacteria Clostridium botulinum. In the UK, 3 different preparations are licensed for spasticity management. So we have Dysport, Botox and Xeomin, and all have slightly different licensing, dosing, ingredients and storage requirements. So the dosage isn't interchangeable. Best practice is to inject under ultrasound or EMG. And it should be delivered by an appropriately trained health professional. It has been shown to be both safe and effective in early and even in early administration, so it doesn't delay rehabilitation and recovery. And it's short term, it effects normally lasts approximately 12 weeks. And so some patients will need ongoing intervention. And we're going to talk more about this as we go through the presentations today. Okay, so how does botulinum toxin work? So I do have a video to play and the music's dreadful, so I'm going to try and stop that as soon as it starts. But I'm just going to orientate you to the slide. So this is a screenshot from the video, and we just think it's going to talk about normal muscle contraction first. So if we orientate you to the picture, the peach area is your axon terminal of your nerve. Orange at the bottom with the striations is your muscle fibre, and the grey between is the synaptic cleft between. And within each muscle there are thousands of these units. I'm going to stop sharing and switch screens and play you a video. So, hang on, definitely got it open. Apologies. Here we go. I think I've managed to turn the video off, the sound off, But yeah, let me just make it bigger. Oh, hang on. So if we think about normal, what happens in normal muscle is, so as I said, within each muscle there are thousands of these units, and when a signal reaches the axon terminal, the snare complex, which includes your synaptic vesicle holding your acetylcholine, which is here, binds with the presynaptic membrane, releasing neurotransmitter acetylcholine into the cleft. I'm going to play along and just stop. So this is your snare protein. So when the neural signal reaches this axon terminal, snare complex binds with the presynaptic membrane, releasing a neurotransmitter acetylcholine into cleft. This then binds with the postsynaptic membrane, triggering the next chemical, an electrical cascade, resulting in a muscle contraction. So when we inject botulinum toxin into a target muscle, the botulinum toxin complex undergoes changes initially, which now allows it to then bind with the presynaptic membrane and enter the axon terminal. This is called your uptake and internalization phase. And then once in the axon terminal, it targets the snare complex. So the short chain of the toxin cleaves, it removes part, and it removes the SNAP25 protein, which then changes the shape. I'm just going to go back a little bit because I wasn't talking quick enough. So it changes the shape of the complex, which means it then cannot bind with the presynaptic membrane. It therefore doesn't release the neurotransmitter into the synaptic cleft, and it doesn't cause that next cascade of chemical and electrical reactions, which results in the muscle contraction. Okay, then over time you do get recovery, which is why it's a short term, around 3 months for most patients. The neuron is undergoes sprouting or budding, and you get return of a normal acetylcholine transmission. Sorry, so there you go. So hopefully that gives you a little bit of an understanding of how botulinum toxin works. I've gone back to share my screen. So you've got 2 videos around how ultrasound is used to localize the muscle, make sure we're injecting into the right place, and ensure we're injecting safely, avoiding blood vessels and nerves, which sit very close to our muscles. So we're going to play you a video around, so the first one is looking at the biceps and brachialis. So we're in the upper forearm. So the upper arm, sorry, not upper forearm, the upper arm, and it's the lower third of the arm, anterior aspects, and this is the right arm. So all our patients have kindly given permission for these videos to be used in training. I'm just going to play this one to start off with. You've got Emma doing a little voiceover in a second.
I can't hear him, or I don't know if anyone else can.
No one else here?
It might be that you haven't shared your audio when you shared the screen.
Oh, hang on. Thank you. Add a little note. I did forget to do that. Right, let's go back.
I can hear it now.
Yeah, fabulous. Thank you. point out where the muscles are, Emma, on the screen.
Yeah.
So
if you're thinking, down here's your humerus, and above your humerus here, we've got brachialis, our dividing line here, and then above we've got, here we've got the two heads of biceps. That's not shallow review.
you can see the tendon, that really bright line is your biceps tendon. And so using the ultrasound, we can really clearly see where the musculature is. And we can also, this video didn't show it, but we can also see where the blood vessels lie as well. And then just to give you an idea about what the injection looks like. So it's an intramuscular injection.
Make sure it's mind your camera side. Yeah, still happy.
Okay, so sharp scratch coming up. Sharp scratch coming up.
Yeah.
Yeah.
Yeah. Yeah.
So watching the needle moving to the muscle.
Right, Carol.
Make sure we're not in any vessels. And then you go to 0.8. You can see the liquid coming in down here. Right. And then you're going to
You win, Emma?
yeah, I reckon. Here.
Yeah, I can see around.
Goes harder with draw a second. And then 0.8 is all in now. You can see the
There
dispersion.
we go, look at that. Beautiful thing. Okay, so Sarah, I need to
Okay, so for those of you who haven't been able to watch a toxin injection, we just thought we'd share some videos of what it actually looks like in practice. There's an awful lot of prep that goes on before, and in terms of preparation, muscle selection, creating a sterile environment, drawing up the medications, but in practice, sort of show you what it looks like in terms of the injection, using ultrasound to be really assured, targeting the right muscle. And you can see that was an injection where one injection site, two muscles, deploying first into brachialis, your deeper muscle in your elbow, as an elbow flexor, and then into biceps on top. Oh, hang on, sorry, there we go. So just going to switch screens. Okay, so what we wanted to do was to show you some examples of how we're using botulinum toxin in practice, and to share some of the impacts that it can create, so you can start to grow an understanding of how it could be useful for patients. So we're going to start off with a gentleman that maybe has quite an arm from that photo that is very familiar. It's an arm held in a position of flexion, slight supination, and the arm is adducted. This is a gentleman that had an acute infarct, bilateral cerebellar infarcts, basal ganglia, thalami, cerebellar, so a multi-embolic stroke. And he was approximately 4 weeks post-stroke when he presented with kind of this presentation. It sort of developed over time. His elbow range of movement, we could get 140 degrees of flexion. You couldn't quite get extension. We did a little bit of investigation into this because he also had a new diagnosis of Paget's disease. So as part of that assessment and understanding the range, the causes, what the possible benefits and impact of injecting could be, we asked for an X-ray, and we felt like he had quite a lot of osteophyte development at the back of his elbow, and that actually that fitted with the picture of him having a bony block. So if we were looking to do toxin, we weren't looking at getting full extension, but we were looking at getting better range of movement. His wrist, he had quite a relaxed wrist. We moved from flexion to extension, 40 degrees of flexion, 20 degrees of extension, and supination, had 20 degrees of supination into pronation, 60 degrees. Using modified Ashworth scale, which is the scale we talked about last time, as around the scale that we should be using to monitor spasticity. His elbow flexors varied between a 1 and a 2, and he had a catch at approximately 60 degrees. He also had spasticity modified Ashworth of 1 in his pronators and wrist flexors, and he had intermittent clonus in those muscles as well. So we had quite a lot going on in terms of therapy management for this gentleman. His active participation was limited due to his confusion and drowsiness, but we had fabricated a softened Scotch cast when that wasn't able to be tolerated, because you can see he has some foreskin integrity issues. He tended to scratch his arm quite a lot. We were using a pillow splint. He was using a leader resting splint, and we had positioning guidelines in place, and we were able in the acute setting to provide regular monitoring of his range of movement and tone. But we're thinking this gentleman was due to be moving out into a nursing home. How would this be managed once he was in the community setting? And we were quite concerned about him losing range of movement, and certainly things around his ease of washing and dressing and maintaining his skin hygiene and integrity. And also thinking that actually this could be an elbow that became quite painful. At the time, it wasn't painful. But, so that's what led us down the route of exploring botulinum toxin with this gentleman. So he was in terms of muscle selection, we went with brachialis, as it's the primary and strongest flexor of the elbow. Brachioradialis, it's a flexor in the mid position. Pronator, as I said, we identified spasticity and clonus in pronators, and also in the wrist flexors, so ulnar, flexor carpi ulnaris and radialis. Oops, made a little bit typo there. So this one is meant to, nope, hang on. Green one is meant to be radialis. I'll change that. Okay, so pre-injection, this is the picture you showed before. This was the sort of natural resting position of this gentleman's arm. And then post-injection, there is a slightly different angle, but you should be able to see that the arm is much more relaxed. And his range of movement was the same, so 140, 20, 0. His modified Ashworth in his elbow flexor had reduced to 1. Used the armour as a measure as an outcome measure, and within part, when I did it at the initial, it was he scored an 11, and then 2 weeks post injection it was a 0. So that looks at the ease of personal care, putting on splints, cutting nails, washing hands, and then obviously photos were probably the biggest outcome measure. What we also found with this gentleman is that he also developed some spontaneous use of his left upper limb post-injection. So we'd had some intermittent, really variable use of his left arm, but it was becoming less and less, and maybe the spasticity in his flexors was preventing him use his extensors. But post-injection, he was able to reach and hold a cup, and also he was starting to use his left hand to pull the mitten that was off on his right hand. So a real change in what his function was. So that's my first case study. And I'm going to move on to Karen, who's got a slightly more complex one. So we eased you in.
Thanks, Sarah. Okay, so if we have a start with that one. Okay, so we're going to take you on a slightly different journey now. So really just want you to all have a think in terms of your clinical practice, how often you have seen this kind of presentation, either within the community, particularly in some of our care homes, or on the wards. And I think for all of us, I think there's a risk that we have felt that it's too late to intervene and that the person isn't appropriate for therapy. So I guess what I want to do is to distill some of those myths that you might hold, and also just realizing that we are all subject to unconscious bias, and that's informed, isn't it, by cases and historical perspectives where we've tried to support this posture management. And I guess the whole thing that we're trying to do here is to really help you to see the opportunities we have for us now in managing spasticity. And for those of us who've been in practice for a long time, this is changing rapidly. So, I'm probably the longest qualified therapist on this call, and I've been in practice for 30 years. So actually, this would have been a case that we wouldn't have probably had the capability to manage as a therapy community. But actually, I just want us to start to really, open our eyes and start to think very differently around some of these more longer term cases. Okay, so if we can move the slide forward, Sarah, thank you. Okay. So this lady that I'm going to talk to you about actually wasn't a stroke. She was a lady with a diagnosis of primary lateral sclerosis, which for those of you are probably aware that it's an upper motor neurone variant of MND. So again, you know, with that diagnosis of MND, we all create some assumptions about how we can manage and what we think the future might look like for this patient. So this was a lady who was under the care of the acute rehabilitation team here at Eastbourne Hospital. She was admitted with increasing back pain from the community, increasing care needs and worsening paraparesis and spasticity in her lower limbs. She had been in 8 weeks previous to this admission, where she had been, whilst deteriorating and challenging with her management, had actually been able to seat and had been able to participate within her care. So when the acute rehabilitation team went to see this lady, they found a really complex picture of pain and tone. And a bit, if we think back what Sarah was just describing with us in terms of some of those oral antispastic medication, which was probably the kind of the options that were available within the community, is that she was on an increasing dose of both analgesia to manage her back pain, but also antispastic medication. And so the kind of the result of this was an increasing drowsiness picture, which, you know, it doesn't take a rocket scientist for us all to know that then that has further impacts in terms of her participation in her care. She started to become more passive. She became challenged to make decisions relating to her capacity. And there were sort of issues, as you could see with that previous picture, around skin integrity, maceration of the tissue behind her knees. And this patient was becoming withdrawn and disengaged. So I've offered that this is a quality of life case here. So in view of the significant postural complexity that related to this lady's spasticity and also that potential contracture, the Spasticity MDT, so myself, Emma, Louise and Sarah were asked to come and review this patient. We didn't all go en masse, it was just a reach out to us. And our findings really were of that complex interrelated picture of both pain, spasticity, but also this lady, as we started to go back through her history, had some long-standing musculoskeletal impacts, which could also be driving her posture. And therefore, on top of this, as I've just said, we had the unhelpful side effects of the oral antispastic and pain medication. So I think the point of this is to say that these pictures are complex and we need to go on a kind of an investigative route to understand the relative contribution and components of it. So I've already given a little bit of this away, but I don't know if people just want to come out off mic just for a minute. I can't see you all at the moment, but just shout out, what do you think were the likely problems if we move on to the next slide, Sarah? Anybody want to shout? What do they think the problems were? So what were we trying to address? Anyone?
Risk of pressure ulcers.
Yep. Anything else?
Loss of range, pain, and I mean, she looks unseatable in that picture, but her quality of life, if she's got progressive disease, is not looking great.
Yep. So thinking about her as a person, what are the other things?
Pain.
Yeah.
Yep. Pain.
She won't be able to eat and drink very well in that position.
Well done, Rachel. I saw you come off camera. I was hoping you would say that. Yep. Anything else, people?
Like hygiene, being able to keep.
Hygiene, perfect, Catherine, thank you. Anything else? What about this lady as a person? What do you think the risks are? You could see from that very first picture that I showed you that she was in a very, very challenged position. So what do you think that would be the impact for her in terms of broader things? Just thinking slightly away from our clinical views for a second.
I guess her role and her ability to participate and that connecting to her mental well-being, being stuck in a difficult position 24/7.
Absolutely, 100%. Perfect. Any last? Go on.
Dignity, because if she's in that position, it's a very vulnerable position. She can't sort of feel active in her life, and she's very dependent on other people.
Yeah.
Isolation
perfect.
as well.
Isolation. Thank you. Great. Sarah, if we can just, if you just press the forward button, it'll bring them up. So pain and discomfort, ability to be seated, skin integrity, respiratory function, poor feeding and nutrition, care and hygiene, low mood, and social isolation. So there was a lot riding on this for us to make some difference. And I just, again, it's all about us just thinking just slightly more broadly around what we consider success to look like. Can I get people to go on mute, please? Kate, can you put yourself on mute? I'll do that then. Okay, so thanks, Sarah. Can we move on? Okay, so to fully understand the options that were really available for this lady, as we said previously, and thinking about that first community of practice, we really did spend some time assessing her overall, really undertaking that full assessment we looked at previously. So this is observation, physical assessment, the feel, the spastic catch, the potential musculoskeletal impacts, what did the pain look like, discussions with the patient and family about what had changed and how long ago, what was that time period. So really trying to draw together all of those potential impacts. So in view of the extreme limitation and available range of movement alongside her pain, as we've already said, those conventional approaches were really difficult for us to enact and were likely to have little impact. So as you can see on the right hand side, there was a rather large MDT that we started to build around this lady to really explore those potential considerations. So what was it that went through our thinking? What was our decision making processes that we explored? So obviously you've got the opportunity to maximize medication, but actually we already knew that we were having considerable negative consequences for her. Intrathecal baclofen, as Sarah's already described, for those of you who don't understand, aren't aware of that pathway, there are often long waits. Our referral is to Southampton or to London for that. And actually thinking about this lady, was that in her best interest? Was she going to be able to undertake that journey to go up to London for the test and then wait for probably about 9 months for a potential intrathecal baclofen surgery? Tenotomy is also another option in our toolbox, but it's a surgical procedure. This is a lady with a progressive, although slowly a progressive MND. So again, what were those high risks in terms of a poor outcome for this lady and the anaesthetics risks? Botulinum toxin. So obviously this is a talk about botulinum toxin, so you know where we're going with this. But actually, having thought about that first picture that I showed you, what were going to be those challenges for us to deliver botulinum toxin? So we need to have clear access to be able to get into those muscles. And with such a severity of contracture, that was going to make life very difficult for us. So where did we end up? So actually where we ended up was we thought about a collaboration with our anaesthetic and pain team colleagues to look at a nerve block to be able to enable us to really fully assess this lady's relative contribution around her contracture. And also to see what the viable muscle was, because actually at this stage we still weren't sure what that viable muscle would look like. And actually if we could use a nerve block to kind of release some of that neural activity into those muscles, it may offer us an opportunity in terms of range of movement to be able to get into those hamstrings. So that's actually what we did. So if we can just move on to the next slide, Sarah. So just a little bit of teaching, just alongside some of the things that Sarah's already shared with you. So although when we're doing botulinum toxin, we often know which muscles we want to target, as Sarah said, we use ultrasound not only to localize our injection and improve safe administration, but we also use it as part of assessment to help us understand the morphology of the muscle and the relative viability of the muscle, which might be amenable to toxins. So, quick lesson here. As with X-rays, the whiteness and the blackness in the picture that you can see tells us about the ease with which a sound wave passes through that structure or is reflected. So the dense structures are difficult for the sound waves to pass through and therefore reflected back as bright white signals, and we call that hyperechoic. So the common ones are bone and tendons and fascia that Sarah already pointed out. And these are important because they help us orientate ourselves. And the less dense areas are often seen as the grey and black and including normal muscle, but also things like vessels, so the blood vessels and also any other structures that we want to look at. So this can really help us to also understand the presence of long-standing spasticity of contracture, because in contracture we know that there's a stiffness to the muscle and it might be due to those intramuscular infiltrations of fibrous tissue or the buildup of scar tissue that has formed due to that prolonged muscle contraction or spasticity. So contractures can be seen as hyperechoic and they've got an increased amount of ultrasound reflection. So they appear a bit brighter. So if you look on the screen, you can see on the left at the bottom a normal muscle, so quite sharp and bright. And the one on the right is somebody with a prolonged spasticity. And actually it looks much more diffuse and more white. So actually prior to us undertaking an injection, we can start to be really clear in terms of whether we think botulinum toxin is going to be amenable, but we can also work with patients and families to understand and manage those expectations of what we might see. So if we can move on, Sarah. So what was it we were going to hope to achieve? What would success look and feel like? So the discussions that we had with the patient, her husband, her daughter, and the broader MDT was around that quality of life. And so our ultimate aim was to think about trying to see if we could get her into a seated position and improve her comfort, because actually from that then would fall out those things that we talked about at the top of this piece of this segment was about improving her care options, her hygiene, her posture for feeding, and then also how she was able to interact with the world around her. So if we move on. So again, as Sarah said, there are things that we need to consider when we are thinking about botulinum toxin. So with this lady, our plan was to inject her hamstrings with a potential consideration for her adductors. But these are big muscles and they require the maximum dose, particularly if we think about the picture of that lady and the degree of spasticity and contracture that potentially existed. We needed to be looking at the top of the dosing in order to be able to have an effect. But actually there is a maximal dose that we can give somebody in one treatment session. And therefore we need to think carefully about how we're spreading that dose, because actually what we don't want to do is risk putting too little into a muscle and actually not having any impact at all. So in terms of the hamstrings, there are 3 muscles. We were looking at both legs, so that's 6 muscles. So therefore that consideration of whether the adductors were involved was something that we were able to explore when we took this lady into theatre, because actually by taking out some of the neural component, we were able to see what was really a challenge, what was actually spasticity and what might be contracture, because if there's contracture, we're less likely to have an impact. It's that spastic muscle that we are having an impact on. And also the other things we need to think about for this lady, the fitness of the patient for an anaesthetic procedure, the informed consent of the risks for a person with MND, and also those conversations as a broader MDT around ceilings of care. So this is a complex case. We also needed to think about the human factors for us as a team. This is not our usual working environment. So between us, between the 4 of us, we have quite a rhythm and flow. We know our roles, we know how to work together, but actually taking this out of the scenario on a ward and putting it into theatre, which is not our usual place to operate, we needed to talk through that scenario. And so we did some of that mental rehearsal ahead of the theatre. So if we can just move on. So really, this is just about thinking differently here. So this is us in theatre. So once the spinal block had knocked out that neural component of her presentation, as a team, we were able to see that her limbs could get into a much better extended position. Paul Harvey, who was her lead therapist, also came into theatre with us because he actually had the better working knowledge of what her muscles looked like and how they responded to therapy. And actually I couldn't locate the picture, but there is a picture. We got her leg, her left leg, I think it was. We managed to get that almost straight in theatre, with one of the legs slightly more remaining in a slightly more flexed position, so telling us that there was a little bit more contracture existing one of those muscles. So the importance of this, guys, I think is what the message I'm trying to get home here is. We see that lady that I showed you at the top of the picture, but when we took out the neural control, our assumptions around contracture were slightly blown out of the water, because this lady did not have as much contracture as her initial presentation would allude you to believe. So if we just go on to the next one. So this is a lady 10 days post outcome. I should have put the other picture alongside it, but I hope you can remember what she looked like. And so actually the team, Paul's team, worked really hard alongside Louise to really maximise her posture, looking at all those opportunities. So really using that window of opportunity to work with her and sustain some of the early improvements that we saw. So if we go on to the next one. So again, so what did we achieve? So thinking back at what we started with, so she was in less pain, she was able to be cared for. So she's initially on the ward, she needed 2 to 3 people for all care. She was able to participate in rolling, participate in her care. She needed care of 1 in the bed, and then actually care of more to be able to get her out of the bed. She was able to be seated. She ate her meals in a chair. She hadn't done that for probably a couple of months, and she went to the coffee shop with her husband, and she was able to resume her love of drawing. And ultimately, this lady went home. And this was not on her plan. Her plan was to go into a care home. So just finally then, so this is what we started with on the left, and this is her 2 months post injection. Thank you.
Thank you. Can everyone hear me?
Yes.
Yeah, fab. I lost audio completely, and I don't know why, but it's all back now. I couldn't even hear what was going on. Right, thank you very much, Karen. I could hear you because I'm sat in the same room as Karen. It was a pleasure to work with this lady and do something that was really challenging for us as an MDT, but actually see such amazing results that weren't possibly expected. Louise and Paul did an absolutely amazing job of really maximising what she was able to achieve after the Botox injections. Okay, so going to move on to Emma. All right.
Yeah, perfect. Thank you. Can everyone hear me okay?
Silence.
Yeah, perfect. Okay, so just a little bit of background about this lady. Some of you may recognise her a little bit later when we show you some videos. So back in 2017, this was a 62-year-old lady who was fully fit and well. And in 2017, she had a left MCA, which was thrombolised, but then had hemorrhagic transformation. So at that time, she came into the acute, but she did really well. She was using initially a steady SARA, but she progressed really well to be independently mobile with a walking stick. Now, she went home, and at that time, she had a non-functioning right upper limb with really low tone, kind of proximally, but distally. She had a little bit of grip, so was using it for exercises, using a light dumbbell. At the time, she was hyperextending around her right lower limb. And despite active dorsiflexion, she couldn't use it in gait. So she was reliant on functional electrical stimulation, which she'd used for following this for approximately 6 years, for the next 6 years. But she was very, very able. She was doing 2 exercise groups a week with a private therapy company, and she was having one-to-one private physio and hydro. So she was doing a lot. Taking us then to 2024. So at this point she was 70, and unfortunately she then suffered from a left frontoparietal lobe infarct and an acute lacunar infarct in the area of previous infarction. So at this point, she became known to the Irvine unit in Bexhill. She was discharged with a steady SARA and assistance of 1 due to being unsafe because of severe hyperextension on the left lower limb. So the right had done really well. She was controlling that well, but now this was the left. So she went home with a steady SARA, awaiting the orthotics team to provide her with an appropriate orthotic. But we were very confident that she would get mobile at that time. Interestingly, her right upper limb function had much improved following the recent stroke, and she was using it really well during transfers. Following this stroke in 2024, she became independently mobile between her care calls with a walking stick. She was no longer requiring the functional electrical stimulation, and she was utilising the orthotic provided by the orthotist. Then we come to April 2025, and she had another left cerebellar infarct. So this lady's been through a lot, an awful lot. At that point, she presented into the DGH. She had, again, right lower limb weakness. So again, it's moved from the right to the left to the right. So it was right lower limb weakness, approximately 1 out of 5. She was full assistance of 2 for all, bed mobility, full hoist to transfer. But there were lots of concerns around her ankle posturing, which obviously you can see in the pictures on the screen. One of the things that made this a little bit more interesting and difficult to assess was her level of anxiety. So if you went to touch this lady, she would scream, she would shout, ow. So it was very, very difficult to assess. But just looking at her resting position, you can see that she's in severe plantar flexion. She's got extension of her both her big toes, the left more than the right. She's got quite high arches, kind of mid-arch of both her feet. Her left forefoot kind of everts a little bit more, but you can also see that her toes are kind of clenching in comparison to the striatal big toe, which is the pointing upwards. The actual rest of the toes are clawing down. So if we can move on to the next screen, Sarah, thank you. That was just a little bit of background. So this is just a little bit more of a closer look as to what we're seeing. So on the left of your screen is her right foot. So again, you can really see that toe and the inner arch, and you can see those other toes kind of clenching from behind that big toe, and the exact same kind of positioning in the left. So we were really, really concerned at this point as to what we were going to do with these feet. So the next slide, Sarah, thank you. So within her therapy, she was doing lots of things that we could work on at that point. So lots of lie to sit practice, lots of sit and balance practice. The acute team made some soft and Scotch splints for her ankles, which she was wearing. I'm not sure how compliant she was with them in the acute, but wasn't very compliant with them here. Trying to do lots of relaxation with her, because we could very much see that even lying in the bed, this lady was nervous. Without you even doing anything to her. She was red, she was flushed, she was sweating, she couldn't catch her breath, she couldn't speak very well. So there was a lot of things that were driving the increase in the tone that we were seeing. And at that time, practicing Oswald restraint encore standing. Unfortunately, I don't have any pictures of that. Kind of before she got to us, but at that point her feet were not achieving a good position. They were not getting plantigrade, and it was probably a little bit. We were very concerned about it being safe due to the risk of kind of ankle injury. Okay, next one, Sarah. So she obviously became known to the Spasticity MDT. So we went to review her. We actually reviewed her a couple of times. This is kind of a bit of a holistic overview, but because she was very difficult to assess because of the way in which she presented with her anxiety, but also trying to work out, was anything painful, or was that her anxiety making it appear to be painful, which we did feel was the main concern there. So obviously in a passive posture, you saw the pictures. What we would say is that the left toe was painful. If you tried to extend that back to neutral, flex it back to neutral, there was a clear pain response to that. But the opposite side, on the right, she could achieve neutral. Knee and hip, she was able to flex and extend them active assistedly. She wasn't able to do that independently, but she could do that with active assisted movements. And we didn't feel that, although again verbalizing and some resistance to movement, you could, with repetition, you could achieve that. So in time, when we stood in the Oswald straight, with relaxation and time, both ankles were able to achieve plantigrade. The right midfoot flattened fully. The toes remained flexed, but they could be extended. The right knee was mildly flexed and was stabilizing by the knee block. However, the left, there was a lot of hyperextension in the left lower limb. And as you can read this in your own time to try and get your head around all of it. But the muscle activity within that left foot didn't stop. It kept going constantly. And the left big toe didn't come into contact with the floor at all. The left pelvis rotated back, obviously with that hyperextension that was accentuated even more, but there was glute activity in there. So there was definitely underlying activity present, but it was very difficult to ascertain what was active, what was tonal, what was anxiety driven. Okay, next one. So we had a bit of a discussion around what should we do, what are we looking at here. So we obviously knew there was a large element of anxiety driving her tone, so that was one of the things that we needed to address. So we did lots of relaxation with her. We tried to keep her therapy team similar people so that they knew her, they knew how she worked. There was a lot of history around her anxiety, so having known her previously, potentially some OCD characteristics which have now been exacerbated hugely. So trying to work on knowing what concerned her, so having things in the right place. So we would get there and do that before she had to worry about it. But also making sure that from a pharmacological point of view that she was maximised. So obviously reaching out to our pharmacy colleagues in Spasticity MDT to make sure that she had anxiety medication. So that really, she's maxed on that now, and that has really made a huge improvement with her. There was some anxiety around discussions around injections, so just making sure that we talked through all of our, we hadn't necessarily made decisions at that time, but we were just keeping her and her husband with us on the journey of what are our options here. Thinking about the fact that she had some previous postural changes and just really thinking, how is that changing what we're looking at now? So were there some previous, obviously she had the hyperextension in that left knee previously, is that something that just hadn't resolved fully? Has the gastroc now become shortened, which is why we're seeing that position, or is that something that is correctable? So kind of just bearing that in mind when we're doing all of our assessments. We obviously knew that she was a severe high risk of losing range, and that meant that her ability to stand for transfers was, we were losing the that as a potential option for the future. So what we decided to do was to do some injections. So obviously when we're doing these injections, we're hopeful that we can make some improvement, as Karen said earlier, but actually we sometimes just don't know exactly what to inject or how much to inject, what muscles to inject. So sometimes that's really clear and obvious, but sometimes actually it's a bit of a learning and it's a bit of a process and a bit of a journey for these patients. So obviously we're the first ones to do it. Most of the time we're the first ones to do it. So we decided to use it as a little bit of an initial assessment to guide what our treatment might be from a therapy point of view. And also kind of when she potentially might be referred to further services, we can say, well, this is what we've done, and this is what we found. And then we hand that over to them to then further kind of analyze what could they do differently? Could they increase the dose? Could they change the muscles that were chosen? So for this lady, it was a little bit of an assessment of what could we do? Obviously, we're probably not going to be able to do everything, and we're probably not going to get it right first time. So it was a bit of an assessment to see, yeah, where are we at? And obviously, as Karen said earlier, when it's bilateral, we're limited to how much we can put in. So it really does make it difficult to ascertain what should we do and how much should we put into each of our muscles. So for this lady, although we saw lots of activity and things happening within the intrinsic muscles of the foot, so our flexor brevis, flexor lucis brevis and things like that, we decided to opt for the left extensor hallucis longus, so the muscle that brings the left big toe up into the sky, the gastroc and the soleus on the left, but then only the soleus on the right. And that was, although we were finding that eventually we got range, that was it took a long time to get there. So actually trying to relax that plantar flexion off, could we achieve a better stand, potentially in a quicker time to allow something like a standing transfer? Okay, Sarah, next one. So this is her outcome. I'm not sure about the timeline, but within a couple of weeks, kind of a week or two. So you can see here in the pictures that she's getting really good plantigrade. There's still some high arch. You can still see a little bit of a high arch within the left foot there. And there was a very, very, very slight increase in her extension of her big toe on the left, but much, much better contact made. You can see a little bit of toe clawing on the right foot, but again, that relaxed off really quite nicely. Sometimes we would get in and do it, other times over time that would relax. And this lady progressed to be able to stand in the oscillatory standing frame for quite a long period of time, playing, sorry, Sarah, just not quite yet. I don't want to give away where we went. So yeah, she was standing playing games. What I would say is that she still needed an awful lot of encouragement to get to this point. So she would want to sit down after a few seconds, after a few minutes. So it took a lot of staff perseverance in order to be able to do that therapy for a prolonged period of time. But what we did find is that from doing this, we were then able to achieve that plantigrade much quicker. So initially it would take maybe 3-5 minutes, but then it became quicker and quicker. And especially we would find a difference come a Monday, it would take longer, but by the end of the week, you would get there nearly immediately. Her left knee still hyperextended in this position quite often, unless we made sure that we got her pelvis in a really good position. But what this enabled us to do was to then translate her to using a Oxford Journey on the board. Some days better than others, but what we did find is that actually her right ankle in the Oxford Journey is more of a problem than the left foot. So yeah, her presentation changes quite a lot. It changes depending on who's doing it, what her mood is. But on the whole, she was achieving much better positioning. Okay, go for it, Sarah. So then this is the next one. And this is quite new. So this is, I think, maybe last week, maybe the week before, from a raised rise recliner. So as you can see, she's pulling up to, the reason we went for the return was because the steady positioning is really quite difficult in our riser recliners, and I felt that we weren't, it wasn't very safe to try and use. So we decided to have a go at this. So if the video plays, you'll actually see how little myself and Janet are doing there. And she was able to stand, she was able to achieve a really good upright position. And she is able to get some hip extension, but she does tend to flex forward in her trunk and let her hips flex, which is quite difficult in a steady sometimes. But she's definitely got the capability in there of a pull up to stand, and you can see she's using both arms really nicely to do that. Ankles are in a good position. That left knee, I'm not sure if you could see, but it was still not touching the knee block when we were up. So that does still rotate backwards a little bit. Now you can see it just kicking in there. So it extends well, but it doesn't, it rotates back. And I'm not sure how new that is, or whether that is actually something that she's been managing with her orthotic before. So we are waiting for her orthotic to come in just so that we can retry that again. What I would say is that we have encouraged her to use some newly fabricated softened Scotch splints or resting boots or anything, but she's really not keen on using anything. So it's really trying to make sure that she sits out as much as possible so that her feet are in a good position, either on the wheelchair foot plates or on the floor. However, she's not the most compliant and is the type of lady who is doing it with the therapist, but not potentially doing it with the others on the ward, which is making it a little bit trickier. Go for it, Sarah. I can't remember what's next, so I don't want to. Okay, so obviously we're aiming for a standing transfer for this lady. She actually, prior to the injection, she went back to the acute because she's been very medically unwell through her stay at the minute. There were lots of discussions about whether she should come back to us or whether she should be discharged because she'd reached her baseline. But we really felt that we wanted to inject just to see what her potential was. And I think from the return is good enough, but also 2 weeks ago we decided to pop her in the Indago just to see what her legs were potentially capable of. This was her first try. We have done it a couple of times since, and even tried standing in the Indago to a gutter frame. So what you'll see is we're not going for perfect here, and her posture's not the best. You can see her trunk flexion, you can see her glutes aren't overly activated, but when you see how much she's able to initiate the walking, you'll kind of see what I see in her to think that actually there is still more in there for this lady. It's going to be really difficult to get to achieve her absolute best outcome, just because of the nature of the NHS, the services we've got. But I'm very much advocating for her that we, Sarah, I'm hoping this is the right video that actually shows the walking.
It doesn't, Emma. No,
Oh,
this is.
I
didn't have
do
another video.
That's okay. I do have it on Teams if I can just really quickly find it.
Yeah, you find it, Emma.
Yeah,
I've been following this lady, so I can happily chat while you
yeah,
find
go
find
for
the
it.
video.
Thank you.
Obviously, I've met Catherine a few times. Yeah, she's a really complex lady. She's had 3 strokes, so actually trying to work out what was happening, what was old, what was new, what was treatable was really tricky from the discussions that we had as an MDT. And then over the last few weeks, I've been popping back in and seeing her progress sort of post injections, and she's amazing. Obviously, Emma was saying that her anxiety was playing a large factor, and some of that recovery has been supported by sort of managing her anxiety, but the botulinum toxin injections she received really helped with kind of that range and that exploration of what her function could look like, and making sure that, you know, she's at less risk of losing range when she actually leaves a bedded setting.
Can you see my shared screen?
Yes.
Yeah, okay.
Oh, that's amazing.
Yeah,
sorry.
so on the oh, hang on, where did it go? Hang on, it skipped very quickly. There we go. So as you can see, she's really initiating, and she's doing independent swing on the left leg, and on the right leg, I'm just lifting that toe a little bit. This was the first time she did it. The second time she did it, she was much more independent with that right lower limb as well, to the point that I didn't need to help it. So it just shows you, given some time for some of these patients that are really, really complex, and I really feel like this lady's got more to give. But obviously, as I said, we're a little bit at a bit of a point now that we need to be having some discussions about what's next for this lady. It'll be very interesting to see how this changes as her toxin wears off, and I will look very quickly in a second. When we injected her, because I can't remember off the top of my head. But what I would say is it'd be very interesting, and I'd be really, really hopeful that potentially we don't see the problems that we saw before creep back in, because we have got her on her feet, we have got her weight bearing, and she is beginning to start thinking about taking some of these steps. I'm going to have a really quick look.
Middle of August, wasn't it? Middle of
August. Was it before we went away, Sarah?
Yeah.
Dun, dun, dun. Sorry, so. Very quickly. She was injected on the it was the 16th of September.
Oh,
actually, it was just when we came back. So 16th of September. So she's kind of a month and a half in, so halfway through. So it'll be very interesting to see what happens as we move forward. So my current thoughts are that obviously we need to see her with the community teams so that they can really build up, because one of the things for her is that she needs to know the person, she needs to trust the person, and that is huge for her when she's doing any of her therapy, and that's been part of the difficulty with the ward. She needs a particular person to work with, to be honest with you. So we need to pick the right people. to support her moving forward in this journey. Not sure that home is an option for this lady. So realistically, we're probably looking at a resettlement, but it's going to have to be one that can support her with potentially a long-term standing program, whether that's the nursing home, whether that's a community team coming in, what the options are around that, because I do fear that if she leaves and this doesn't continue, that she will end up losing range and losing function and potentially end up hoist transfers. So I feel like we've done so much work that needs to kind of try and be translated onward now into the community. She'll potentially need on referral to clinic, but it's really interesting to see over the next kind of month and a half, how will those muscles kind of, will they return in the spasticity, or actually have we managed to prevent that from happening? I'm not sure yet, so it'll be really interesting to see moving forward. Does anyone get any questions about that? I think, is that my last slide, Sarah?
Yeah, that is your last slide.
Okay, does anyone get any questions? I think a lot of people have come across this lady, so.
There'll definitely be time for some questions at the end as well, because
Okay.
we've given you 3 sort of case studies and maybe think about, mull over. It's just a really good example of, you know, all the examples of where we've used toxin is that, you know, we've used it to create a window of opportunity to really maximise the therapy management for these patients, to put in place those therapy management options, the standing, the splinting, weight bearing, to help see what, you know, to really create the right environments to maintain and control spasticity. Right, I'm just going to remind you of kind of referral routes in before we open up for any questions. Okay, these are my maps. So we have our Spasticity MDT. These are slides that were sort of shared in the last session as well. So if you have any patients that you think you would benefit from a review, from spasticity assessment, some conversations around antispasmodics, pain relief, really happy for having those conversations. So you can contact myself, Karen, Emma, or Louise. We have a weekly Spasticity MDT on a Tuesday, and the email address is esh.spasticitymdt@nhs.net. At the moment, we are in a position where we can provide botulinum toxin in the bedded setting, so in acute and rehab beds. We aren't able to provide by ourselves into the community setting at present. So the routes for accessing when patients are in the community setting is through Sussex Spasticity Clinic. We are growing the evidence that we need a local service. So if you are referring patients to Sussex Spasticity Clinic, please can you just let us know so that we can start to gather that evidence and that information to support a local business case, so that we can in the future develop, you know, have a much more local provision, because we know for some of our patients accessing Sussex Spasticity Clinic at Brighton General can be a real challenge because of some of the logistics there. I've just switched screens and have seen a few people have got their hands up, but Emma, do you want to come in now?
Yeah, I just wanted to say, just to clarify with saying about the bedded units, it is only BIU at the minute. We're unable to reach out to Rye or Milton, obviously. It's literally just the BIU due to the prescription of the toxin. So yeah, it's not all bedded units, it's just Bexhill.
Yeah, thanks for that, Emma. Sorry, I forgot about that. Georgia, you've got a question.
Yeah, I was just going to say, obviously, it would be amazing if we could eventually get it to for access for community patients in the area. Is there any other way that we can like make a case for that, other than kind of letting you guys know, there's someone that could have benefited from you? Like, is there any other way we can kind of demonstrate that need?
Shall I come in on that one?
Yep.
So absolutely, what we need to do is continue to make that case. So I think it's about we're in a between a slight rock and a hard place, I think, Georgia, and I think your role particularly is helping us to surface some of those patients. So, you know, we have in the past perhaps not had the capacity to be able to support some of those patients with longer term needs, particularly those in care homes. So I guess where we're trying to get to is this is about appropriately using the Brighton resource for patients who can travel, but for those patients, a bit like the case study that I showed you, if that lady was in the community and she was, that would have been extremely challenging, if not almost impossible, to have got her through an outpatient approach to go to Brighton. It wouldn't have been the right thing for her. I think the logistics of travel would have been difficult. And so what we're trying to look at, I think, is more of an outreach approach for those housebound, bedbound patients who cannot optimize their care through Brighton. So there's two things, isn't there? So one, the reason that I think that those services have across the country not evolved is because of that ability to have a line of sight on those patients. So as we move forward with a needs-based approach and an understanding of proactive and long-term care, the way in which we deliver therapy in the community has to change. So this will be looking at those patients who don't have just short-term goals, but looking at those patients with long-term goals. So as we start to do that more, we're going to see more of those patients. So there's a couple of things, and I guess this is a really good request, Georgia, for everybody on this call, is to start to think about those patients and let us know. So even if we cannot provide that care in that way to that person in that home situation, please let us know, because the volume at the moment, it's difficult for us to make the case because we don't have the volume of patients, because actually there's an unmet need and actually we're not surfacing these patients. So that's the first thing. I think the second thing is, if we have got these patients, is beginning to think about, so you know, the stroke community out there is beginning to think about, what does that look like? So what we know is that when we have got these patients, our clinical teams are needing to spend quite a lot of their capacity going back in and trying to resolve and improve the situations for these patients. But actually, we can't actually address the problem that's most pertinent for this individual. So there's also something about, when we do have these cases, is almost doing a couple of case study pathways. So how much time are we spending? What are the impacts for the patient? So again, thinking about those outcomes. So again, what are those quality of life impacts? Because that's where the story is. The story's in the hearts and minds, isn't it? You know, so we've just shared the lady that we took into theatre. That's a real hearts and minds story, isn't it? You know, this was about the difference that actually, I remember Paul saying he'd been on holiday not long after we'd injected this lady, and he came back from his annual leave, walked in to the front entrance of Eastbourne, and there she was sitting with her husband having a coffee, and he said, you know, he's a grown man, and he was like, he said, it really got me. He said that's the story, isn't it? That's the important thing, as well as what we then also need to think about, and this is where Louise and I be really keen to get that information from you, and particularly your post, Georgia, is what are the consequences of us failing to do something? So if we don't intervene, actually the number of readmission rates that our patients have with these complex needs, you know, not only the human cost, but also that kind of productivity cost for how much it costs to manage a skin you know, a pressure ulcer, you know, the cost of a respiratory infection, the risk of mortality and the risk of harm. So I guess what we need to do is, you know, we have, it is on the agenda. We have it in our sights, but it has to be a competing priority amongst everything else. So what we really need is that feedback from the number of patients who would benefit. But what's more important is the risks and the consequences of us failing to be able to manage that spasticity. That's what we really need. So it's those case studies and those consequences of what's happening. So that's what I would be asking people. The more you can send those examples to us, you know, whether that be via Louise, that's probably most appropriate for community. If you send them via Louise, we can start to build that case that actually, as we shift our care proactively, this is an important part of our delivery that we need to enable us to maximize our therapy, because we are.
Oh, I think you've muted yourself, Karen.
Sorry, I don't know how I did that. Can you hear me now?
Yeah.
Full flow. So there's obviously a productivity piece here as well as the human cost, is that actually the number of times we are sending out our probably fairly highly qualified, highly registered staff, the higher bands, to go out and look at this complex case. But actually, you're not really able to achieve that kind of meaningful change, because we can't address the problem that is causing this complexity within her case or within the cases. Does that help?
Yeah, absolutely.
So information is key to us. Data, in whichever form it comes, is really, really helpful for us.
Yeah, great.
Catherine, you've got your hand up.
Yeah, I was going to say something really similar, because obviously I'm assuming the patients that can't access Brighton wouldn't be referred because they wouldn't be able to access that service. So I'm just thinking probably needs like a tracker of those patients that are out in the community that aren't eligible for Brighton, because I think there's probably a huge unmet need, and we know it tends to be the patients with the more severe consequences that all of these things become more difficult for. So I don't know if there might be a tracker already, but I think it would be probably quite useful to have some sort of system of recording that. And I was also just thinking about that lady from your case study, Karen, and thinking the same thing, that if she hadn't had an acute admission, she probably wouldn't have had any of that input. So I'm just thinking about like wider neurology services, because obviously we're a stroke pathway, stroke focusing on stroke, but obviously MND, MS, those sorts of services. I'm not sure how they're kind of quantifying their unmet needs within their populations, or if it's just not kind of recognised as that, because I'm sure she's not alone in the patients that are out in the community that have got different neurological diagnosis, that have got those kinds of presentations. And I know that there are some spasticity, or maybe not spasticity, but botulinum like injection clinics within neurology, but I don't know what their criteria is for what type of patients they see within neurology services. And this is going to sound potentially like a really stupid question, but it's just because I don't understand in the way that you do about spasticity. So with that lady, obviously her spasticity was caused from like motor neuron issues. Is that different to how you would look at like a contracture post-stroke? Because obviously the mechanism of it might be different.
Okay, so shall I pick up some of these?
Sorry, yeah, that was a lot of waffle.
No. I'll pick up. I'll try and go in order. So I think in terms of the first question about the tracker, so we have got a tracker, and we do. The community teams across JCR, across Community Stroke, are invited to join that MDT on a Tuesday. So everybody has that invite to attend, and I think definitely start to tell us about those patients, and we do have a part on our tracker for those patients who are in the community, so we can start to build that profile. But I think it comes back to that point that I was trying to make, that we're definitely between a rock and a hard place, because we need to start to have our community teams being able to be involved in some of these more longer term cases. So as we transform our care in the community, that is very much going to be part of our future, is supporting and managing. And Georgia's post is a really great example of how we're starting to shift that narrative into thinking about people with the long-term care. There was a middle bit before I come to the bit about spasticity. Catherine, what was the middle bit you asked me? Sorry.
Was it about the neurology services?
Neurology services. So in neurology services, they haven't traditionally. So many of you will know that I have been on this journey since 2012, developing spasticity management services around botulinum toxin. And because we were unable to use botulinum toxin for spasticity for quite a period of time, that's now not the case. But because we were unable to use it, those services, I guess, within neurology hadn't developed. So neurology does use botulinum toxin, as does ophthalmology, as does other parts of I think anesthetics are using, I can't remember. But anyway, neurology tends to use it for dystonia. So they have a dystonia clinic where they use botulinum toxin, but they don't see it for spasticity. So that's the space that we had got ourselves into. And then, but what we've been discussing, so a really good example is, so with the complex case that we have just shared, we have a similar patient currently within the community with a very similar scenario. But because this patient is in the community, so again, anaesthetics keen to support us to look at how we do this. But again, anaesthetics are a bit like neurology or you know, or other teams, is that they don't necessarily have admitting rights, so we wouldn't be admitting that patient. So we need to further and understand some of the governance around this, so a parent medical team that would take on the care of that patient, and how we would start to do that. So we're just beginning to explore with anaesthetics and potentially with neurology how we could start to do that, because there are some of those things that we need to bring somebody in terms of an outpatient. So we can do it as an outpatient activity, and that could be under a neurology parent clinical model. But anaesthetics wouldn't necessarily bring somebody in. Anaesthetics are a little bit like us. They work alongside clinical teams, even though they're medical. And then your third question was about the spasticity presentation. So spasticity per se is the same. So whether it's a spinal cord or whether it's a stroke, what's different is the way it presents in the muscles. So there are different focal patterns that we start to see in relation to that. So for example, spinal spasticity will look different in some of that presentation to how stroke, but the mechanism and what we're trying to achieve is no different. We're just trying to look at that in some of the different muscles. So I think I'll stop there. Louise, do you want to come in?
Thanks. I've just popped into the chat as well. Just on the first point about the tracker, of course, Karen, you've mentioned that we do have a tracker, but also just to emphasize again to community teams to please be ensuring that where somebody has a need that should be assessed and managed by the Brighton Clinic, because that's our specialist service at the moment, that regardless of whether you think they can get there or not, we need to refer them, because that is one of the ways in which we are highlighting the unmet need. That means that the consultants at that clinic are able to also see those patients. So we've had one patient that we sent across and they came back to us and said, we're not sure how we can get this patient here or how we can support the needs. But that's opened up a conversation with us and that service, which will help with the overall conversation and discussions and sort of that motivation for a community-based support that's more local. So yes, so please, just for equity for those patients, make sure you're referring them even if you don't think they can get there. All right, we'll track those ones. Thank you.
I'm glad you mentioned that, Louise. I was going to just quickly say that as well. Right, we have overrun. If anyone does have any other questions, please do put them in the chat. I will have a look at it later, direct it to the relevant person and get back to you. I just wanted to really quickly share my screen. I know we have overrun. If you can fill out the feedback form for this session, it would be brilliant. It's really helpful for us. It helps shape the future sessions, starting to think about what goes on in 2026. So there's an opportunity for you to put ideas of future sessions in there as well. I do look at the feedback, I do analyse it, do use it to inform. So please do take a few minutes. It's 4 questions. Fill out. I've put it in the chat as well. I said we had a lot to get through. I'm really sorry we've overrun. I hope everyone's found it really interesting, sparked some thoughts, start to see some other opportunities. This is a service, as Karen said, that has been growing over many years. I feel like we're getting to a point of real sort of accelerated growth. So this is really exciting for our patients. Just thank you very much, everyone. Have a good rest of days.